I'm Dr. Xiaohui Niu, and I from Beijing Jishuitan Hospital. It's an affiliated hospital of Beijing Capital Medical University. And I work in this hospital. It's an isolated department. It's called bone tumor department. Not only medical oncologist, but also the surgeon. We have 1,500 patients a year. And we have a database, and everybody can visit our database. JST, sarcoma.net, and the Dai Sangong, they connect me for the clinical trial in China for the Paxidactinib, and we start that. So after finish that, and then we continue with the EBSCO, and then we start the PIMI in China first. So that's why I'm the PI for the Pimicotinib. So TGCT before 2002, most doctors think it's an inflammatory disease. And after the 2006, they find out that the mechanism of the tumor behavior, because there is a translocation of the CSF1. And then there is tumor cells from the synovial membrane. And these tumor cells, because they got the genomic abnormality, and then they got the overproduction of CSF1. So they got more and more CSF1, this protein. The protein they produced, and this protein they get more, the inflammatory cells like monocyte or macrophage. And then they got all this around the local area, only around the tumor cells. And then the proliferation at the same time with this inflammatory cell and with the tumor cell, both of them, they composite, it's like a tumor. And the inflammatory cell help the tumor growth. And the tumor grows, and then they produce more pathologic CSF1. And CSF1 will connect with the CSF1R on the macrophage or monocyte, and then they stimulate the more activity and have a longer life and then longer span. And then we call it vicious cycle, and then they come to growth because usually they occur on the where the atomic site can have the synovial cell. So it's only at the joint, at the tendons, and then because they are very inflammatory, and then they can affect the surrounding structures with edema or like arthritis or something. And then so they invaded not only the synovial membrane, only they also affected the bone, the cartilage, the ligament, and then they influence stability and still the subchondral bone, and then they have a huge mass, and they got mass and the limited of the function of the anatomic structures. Only treatment histologically is only for resection because there are two types of localized and diffuse. Localized usually they are digit, even in the big joint still there is a localized, but for localized, so you just do a resection, it's okay. But for diffused, because usually the doctor do not know where the tumor spread inside this area. And if you do the resection, you should do, because all the mass is only less than 20% of tumor cells. The others are the reactive inflammatory cells. So it's very difficult to do the, precise resection to remove all of this. And at the same time, if you do the tumor surgery, everybody knows you should resect the surrounding tissues, and then it's you will resect more normal anatomic structures, and they make, the joint function. They lose of joint function more, and even though you could not very completely to remove this, and so that's why for diffuse type they got a lot of recurrence rate. I estimate this you mean because for a maneuver study, there are three parts. In part one, it's already reported in the ASCO this year. So for the ISMO, we only to report the part one and part two together. So in the part one, the patient will randomize 2:1 and ratio for study group and control group. Control group is with a placebo, and the study group with Pimicotinib, 15 milligrams a day. For the part one, after they get the drug for 24 weeks, and then they do the evaluation. Firstly, the result is the ORR by RECIST is 54%, and the control group it's 3.3%. At part 2, the control group will switch to it's open label. So the study group will continue to use another 24 weeks Pimicotinib, and the placebo group will switch to the open label and take another 24 weeks of Pimicotinib. For the switched group, so that means they initially they use only for 24 weeks of Pimicotinib. This group, actually we focus on the study group because the study group will have a longer follow-up. Is already used drug for nearly 50 weeks, so that's a year, and then we'll compare the part 1 and part 2 group. So still deepen the effects of this drug. And ORR increased from 54 to 72% because actually it's a joint disease usually. So if affect joint, so there must be affect the function of the joint. So we also to evaluate the function of the patient. So at the part 1, already the patient function improved. So we evaluate the function by the motion, the range of motion, and the function at the beginning, all the function improved. But at the part 1, and still also the function will keep improved. And so the ORR deepened and also the function keeping improved. So when we talk one drug, usually they have the two phases. One is effect and the other is toxicity. And already said that I was the PI for Pimicotinib. So I know this is my first time with the drug like the TKI for benign aggressive disease. So we take a lot of care for the safety of the patient. In maneuver study, and the patient usually, there's side effects, it's not so severe for the part 1. And in part 2, there are no new signals of the toxicity appear. Everything we compare with the primary analysis, they are totally the same. So they can keep the safeness for longer. They can keep the safeness and still they continue to have their function to deepen the function. And because TGCT usually could not treat the disease for this patient, usually stable is the most important. And if you're stable, the patient quite satisfied if with minor or no side effects. But all this disease will keep to the size will decrease. Even in the whole year, it's still keeping decrease. So this is very important for us because it was a hopeless disease, for very advanced cases. In my own opinion, so because now we do the clinical trial in the way of malignancy and evaluating this in malignancy. So actually, maybe that's not fair for the aggressive benign disease because all this kind of disease appear very gradually and they keep growth. So that's why the patient usually they could not bear the disease and then they go to see the doctor. We already know the surgery now helpless, the radiation now they helpless. So the only thing now we rely on is for the medication. This patient not like cancer patient. If you stop the disease, most of the patients were very satisfied with the treatment. And if we can do it to make it smaller, and smaller, they will be more happy. Happy by the months pass, but they could not tolerate is the toxicity. We'll need to decrease the toxicity, but all the toxicity for produced drug. So there must be some toxicity. Usually, they should appear with the dosage. You have higher dosage, and then you have higher toxicity. But for cancer drugs, they want to use the full dose, and then they have more effect. But the disease is chronic. We should treat it like chronic. And if we saw the mechanism at the beginning, the patient usually, when they get the first symptom and then go to the doctor, the interval will be 2 years. So that means it will take time to let the disease to get symptomatic to make them to see the doctor. So it's a hypothesis. So that means at the beginning, the tumor overproduction, the CSF1. So you get more CSF1 and then you can attract more inflammatory cell to stay with them, they grow together. Without inflammatory cell, the tumor will grow already. Yeah, it's proved by the drug treatment. I think, but at the beginning, there will be a much more protein produced. After treatment, all the ability of the overproduction, CSF1R production already decreased. So maybe it's unnecessary to treat already treated patient with the previous high dose because they want so many pathologic CSF production. And then maybe with the decrease of the dosage and maintain the treatment effect, and we can decrease the toxicity and make like a hypertension. With this drug, everybody can control the hypertension, but we don't have varying another heavy or intolerable toxicity. So that is, I mean, the later study will do this work. So because the patient maybe, I mean, they just don't want to have the symptom, they don't want the disease to interfere with their daily life. But if we keep this and then no toxicity and even the pills, I think that will be maybe the future way. Actually, because it's ultra rare disease, and there are a lot of understanding. They don't understand this disease by doctors, by patients, by their families, and now this quite a new drug appear. I expect is that maybe from your media we can let more doctor to know this, and then they will need some training certainly. And we should know the patients and to understand this disease, and they can take this medicine at the right time, at the right interval, and they need to see the doctor. And this could help the patients because we have some late stage. Even we have some people we had to amputate the patients because amputate make the patient more activity than they have the tumor, with the tumor. It's huge. So we just want to how to serve these rare disease people.